All right, welcome back. Yes, we will discuss the situation with the health sector. We're joined this morning by Dr. Mamora, Minister of State for Health. Good morning, and thank you for joining us today on the program.
Thank you very much. Good morning.
Okay, but before we get into the health, just briefly, the retreat that ended yesterday with the ministers, the presidents, the executive president there. Well, yes, we've heard excerpts of the president's speech, but what did ministers leave there with? I mean, for your ministry, for instance, what were the takeaways in terms of performance and what you intend doing in the ministry moving forward, which Nigerians can feel that, yes, indeed, this is what we're going to do to impact your lives?
Thank you very much, Chamberlain. Now, well, the whole essence of retreat in itself, first was to do a kind of stock taking, within the last 1 year that we've been in office, courtesy Mr. President appointing us to his cabinet. So do a kind of stock taking, to do a kind of reflection of what had gone on, what had transpired in our various ministries in the last 1 year, and also look at, retool, the need for us to retool and then re-strategize for the future, particularly in the remaining 3 years, well, which probably will be more of 2 years because of politicking that will come in towards the end of the tenure. And in that regard, for us in the Ministry of Health, don't forget that consultants were brought in, who are experts, to do the assessment, and kind of independent assessment, and look at what we have done well, what we need to do more, and then, of course, setting priorities, particularly this period of COVID-19 pandemic. There will be need for us to reprioritize and look at what the quick wins can be within the health sector. So we have looked at all this, and what we have come up with essentially would be for us to beef up, ramp up the primary health care, which is is at the base of the pyramid of healthcare delivery. 2 is for us to increase our collaboration with the other tiers of government, the state, and of course, through the state to the local government, and of course to the communities. So we need to increase that, that collaboration for effective healthcare delivery. Then, of course, the basic primary healthcare delivery fund, a basic healthcare fund, we also need to operationalize it, and this will help us to achieve the universal basic healthcare, which really captures all that we want to achieve within the health sector, in terms of health promotion, in terms of disease prevention, in terms of treatment, in terms of rehabilitation, and of course in terms of palliative care, because the whole concept of universal health coverage is captured under that.
Okay. How do ministries or the executive approach or relate with, for instance, when they read the dailies or watch the news or go through social media and they see people raise concerns about perhaps the economy or how they think that, well, it's not hunky-dory for them. They think they could be a lot better. The economy is tanking in spite of what the executive may have done. How do you approach that when seeing all of this and then people saying, look, we don't feel some of the good things that you may have put in place?
Well, the popular saying that he who feels it knows it. Those who really, of course, if you're not ill, you may not feel what it is to be ill, and if you don't go to the hospital, you may not appreciate, what we are talking about. That's why I said earlier on that the need for us to prioritize, because the COVID-19 has affected lives and livelihood of our people, and it has affected even the economy, the economy of virtually the entire world, all the nations of the world has been affected. That is why we need to do some prioritizing and look at what we can achieve within the ambit of what is available to us. And that's what we were doing, and that were issues of, that's why I mentioned primary health care, because that's where you have a lot of things, your antenatal care, you have issues of nutrition, immunization, name it. Those are the basic things that we need to if we have very functional primary health centers, and when we say functional, that is having all the things that would make them functional: electricity supply, water supply, the human resource for health, and the basic or the essential drugs. Those are the things, and these things are there, and you know that the bulk of our people, they live in the rural communities. So that's why if you can take care of them, of course, it's less number of people that will require secondary care, and of course, lesser number again that will require secondary care. So we need to focus on this, and we need to also ensure that as much as possible, the higher levels of care, that is the secondary, as in the general hospitals and the tertiary centers, as in the teaching hospitals and the federal medical centers, they are also functional. You see, if we reduce the burden, if we get it right at the level of the primary care, we will reduce the burden at the secondary care. If we get it right at that level, again, we will reduce the burden at the tertiary care.
One of the key takeaways from the retreat is the fact that the president said that, you know what, you need to package your information well, package your achievements well, so you can sell it to the people that this is what we have done in the past 1 year, and this is what we'll be doing moving forward. And I think it's also important to package maybe the KPIs, because you said that there was evaluation, and I believe that KPIs were given to the ministries at the onset, saying these are the things we needed to achieve in this period of time. So regarding the KPIs, really, how much of them were you able to achieve? How much of them would you even be sharing with the public that this is what we're able to achieve, this is what we could not do? Because it's important in the packaging scheme. People need to actually know what is happening.
Yeah. Now, I mentioned the basic healthcare provision fund, which is a provision of the Constitution, of the National Health Act. And of course, we that is in place, and we're able to operationalize that, because it is from that because it has gateways through the National Insurance, NHIS, National Health Insurance Scheme. Then, of course, because that is, once you can have, you can increase the net and make the national health insurance compulsory, as opposed to optional situation that hitherto existed, then you will have more people that the funds will be available to cater for. So, and that it's in process right now, and it's going to be supported by the basic healthcare fund. Then, so that is one of the things that has been done. Again, the issue of polio. Don't forget that just a couple of weeks back, we had that certification. And, it's something to rejoice about that Nigeria has been certified polio-free. Hitherto, three nations of the world, Pakistan, Afghanistan, and Nigeria, were in that unenviable company. But we have exited now, and I think it's something to cheer. That's part of the mandate that we were given, which we also achieved. Of course, we are also working on attracting private sector involvement through PPP arrangements. So we have so many of them going on in various stages. But the ones that we have achieved so far, we have PPP at the Lagos University Teaching Hospital, in diagnostics, which is there, and that has been through the sovereign wealth investment. We have in Luth, we have in the Aminu Kano University Teaching Hospital, and we also have in Federal Medical Center, Umua here. And those things are there, which, because one of the most important aspects in patient management is the ability to make accurate diagnosis. And you need these tools, you need this equipment, you need these diagnostic tools to be able to make accurate diagnosis. So that is also something that we have done, and it's there for people to see. Then, of course, even the issue of taking care of the what you can call the specialization of doctors through the residency training. Of course, we've been able to capture that in the budget, and is to pay for the residency program of our doctors. Of course, that has also been achieved. It's part of the achievement of this administration through the health sector. Yes, there are other things that we have under KPIs, but then which the issue of COVID-19 has disrupted. But even as at that, we still, COVID, may end up just being a kind of blessing in disguise, because if there is one sector that stands to benefit with this COVID, it is the health sector. And we can see that they may not start manifesting immediately, but in terms of looking forward to the future, these things will start, because we have so many hospitals, isolation centers, infectious disease hospitals being put up in virtually every state. And of course, we have a situation now where we have the molecular laboratories being set up throughout the country. And probably all this wouldn't have come to be if we didn't have COVID. So these are some of the things, in spite of COVID, we're still, in fact, that of polio, a program that we're still able to maintain in spite of COVID, which has a tendency to divert attention, but we are still able to achieve that as polio-free certification.
Okay, so
these are some of the things, of course, we're
all right, pardon me. Speaking about the resident doctor strike now, they say that all the demands since June 15th, none has been addressed, apart from a few PPEs that have been provided. And then one wonders, how can that be?
That is not true. I can tell you that is absolutely false. But let me start by saying first that I want to pay tribute to all the health workers, not just doctors, all the health workers that have put up very, gallant efforts, particularly at this COVID-19 pandemic period. Because these, particularly the frontline workers, be they cleaners working in the isolation centers or the treatment centers, workers, health workers in the emergency accident and emergency centers. Then, of course, in the various even border port health services, because they are the first line, people, workers, So I want to really applaud what they have done so far to bring us thus far. And secondly, is to say that it is regrettable that we're having this strike action at this point in time. But having said that, the third thing is I also want to thank doctors and the other health workers who are still able to maintain some skeletal services, particularly at the treatment centers, at the isolation centers, at the emergency, accident and emergency centers, in spite of all this. But having said that, now, one, you see, we should get the facts right. One, we have been able to pay the hazard or the COVID-19 inducement, we call it, because we had to suspend the hazard allowance for this period so that we can go into renegotiation after the... So what we said was that we were going to pay for 3 months, April, May, June. Now, we were able to pay April, May fully. June, part of it has been paid, but not fully paid. And it's because of what we all know happening in our economy, and these funds have to be sourced for one way or the other. And at the last count, we've been able to disburse close to 20 billion. And I repeat, close to 20 billion. So to say nothing has been done, that is not true.
If I could just follow up on that.
Now,
Pardon me.
No,
so that you don't lose your train of thought.
I need to say it.
You will, but I just need to follow up on that particular point so we don't lose it as you say the second part of it. Because they say, first, hazard allowance that they've been seeking to amend that for almost 30 years. That is 5,000 naira. So is it the 5,000 naira that you say has been paid to some of those? And was it federal government that paid federal doctors, or has it been paid across board, including states? How did that? How was that carried out?
Now, you see, I mentioned earlier that we suspended the 5,000. You see, 5,000, what is 5,000? It's so paltry. This is something that has been in existence since 1992, 1993. So that was why we had to suspend it for this period, so that we were now paying starting from about 50% of the basic, 50% depending on where the point of operation is. That is, if you are working in the front line that I mentioned, you're working in the treatment center for COVID, or you're working at isolation. So we had to do the risk assessment. That if you are an account officer, that you are not working, you won't have the same. But we started the gradation from the front, which is 50% of their basic. So that was what we did regarding that, and we then scaled it down to other depending on our assessment of risk that each health worker faces at a given point in time. Now, so we've been able to do that for 2 months, April and May. June we have started, but not complete. But we are still on it because of the limited funds. And I just told you that so far, 20 billion has been expended for this. And of course, because of the shocks that we have in the economy, as well as resulting in the lower earnings, that we could not go the full hog, but we are still sourcing for that. Then the issue of residency training program. This gulps 4 billion. It's been captured in the budget. It's been appropriated. But government processes tend to be, somehow slow. So it's just the implementation in terms of documentation and all that remains. The doctors themselves can confirm that it's in the budget, it's been appropriated, and of course, it's just the nitty-gritty of release that is being worked out.
But, yesterday
Then,
as well, pardon me
the
again,
issue
my
of
apologies.
PPEs, which you mentioned.
Yeah, they say that the question about it being in the budget, they also said that the ministry or the government has always tell them that some of these things are in the budget year on year, I think for the past 2 or 3 years, but they usually don't get it at the end of the budget cycle. So if you're saying this one is in the budget, is there a definite date as to when they can access it?
You see, no, again, that is not true, this particular one, because the doctors, you see, what the difference this time around, or what we did the last time, was that we brought everyone involved on board. The Ministry of Labor and Employment, of course, the Ministry of Health, which is the primary ministry concerned. We brought the Office of the Accountant General, the Minister of the Ministry of Finance, Budget and National Planning, the National Salaries and Wages Commission. Just name it. We brought everybody. We were all together. And we worked on these things, and everybody knew what to do at a given point in time. So that's a major difference from what had obtained before. Everybody this time around, the doctors themselves were there. And of course, NMA, NALD, all the bodies, they were there, the other professional bodies, Pharmaceutical Society, Medical Lab, the representatives were brought together, and roles that particularly on the government side that each person will need to play was assigned out and put in place. But like I said, this money has been released. It's now a question of nitty-gritty. Nitty-gritty in terms of we need to know who the resident doctors are in the various institutions. And it will have to be collected from these centers, because somebody might start a residency program and probably not even there again. Could have gone out of the country, for one reason. So we need to know, so that at the end of the day, we are paying for those who are really undertaking the program. So to say that it's not like if it ever happened at all in the past, it's not the same this time around, because everybody was brought together. Then the issue of the PPEs, of course, you also mentioned that they agree that is no longer an issue, because it's been taken care of adequately. Then,
Honourable Minister,
at the last engagement we had.
Just one moment, if you don't mind. You said earlier that there was something that government had to do, take off certain amount of money or certain allowances they were getting. You had to suspend it for a while. And, of course, a number of other things came up. Was there a conversation with the doctors or the health workers at that time on that matter? Because, to you, the 5,000 naira may not be anything, but to them it could be a lot. So was there a conversation with them before that action was taken, or any such?
Yeah. Yes, there were. We had not just one, we had conversations, series. Because what we said was that, look, that amount could no longer even hold because of the amount. And we didn't want to say that. What we agreed was that after the COVID period, we will sit down to renegotiate that, because it will now be a question of, emergency thing. We're taking care of the inducement, as we call it, COVID-19 inducement allowance for this period. That's what we said. And then we can then sit down to renegotiate the hazard allowance, which is routine, as it were, quote and unquote, routine for the
another issue that I think
health workers, not just doctors.
All right. Another thing,
we all sat down together.
Yeah. Another thing that perhaps would be of concern would be whether or not it's the same thing at the state level as it is at the federal, because not all of them are federal workers, and consequently, if it is happening at certain levels, our correspondent went to town and said that certain people got paid and certain people didn't. So if that conversation goes out, the assumption then would be there is something happening that they do not understand. So is this same conversation happening at the federal level also happening at the state level for all the health workers?
Well, thank you very much. We have made it very clear that it is not proper, it is not appropriate, and it is even unfair to visit the sin of the father on the son, or vice versa, or visit the sin of the son on the father. The federal government takes care of federal government workers. We cannot, as federal authority, dictate to the states what to do. We can only appeal to them within the ambit of working in the same system, that is, or in the same country. We cannot. We can only appeal to them, but we cannot force. That is the truth that must be told. We have said that several times. And what we have seen over and over is that when this strike action, gets on, then it's lumped with what the states are doing. And FCT, the states and FCT administration, they are separate. They are not. With the federal government does not. It is not within the contemplation of the Constitution in a federal setup. Okay, so that is the truth. But we can appeal to them.
Okay. Concerning that particular point, we would like you to shed a little more light on that, but that will be when we return in just a moment. Please stay with us. Welcome back. We're continuing our conversation with the Minister of State for Health, Senator Olorunniyi Mamora. You were talking about the states and at the federal level, but the doctors equally said, some of their comments yesterday was that, well, some states have domesticated this act, but they have not done anything in terms of implementation. They also say it is the same thing with the federal government. I think, if I remember properly, they did talk about 2017, and that ever since then, well, the Medical Residency Training Act, which was domesticated by FG in 2017, has not been implemented. Is that correct?
Well, that is not to my knowledge in terms of you see, the point I've made is clear, which is that the states, yes, if some states have domesticated, we appreciate that. And that is the advocacy. And you recall that at the commencement of this engagement, I did say that we working on collaboration with the states, and through the states to the local government as well, and through the local government to the communities as well. And we have this engagement at various levels through the Nigeria Governors Forum, which we meet with them, and we advocate certain things, and we encourage them to do certain things. We also have the National Council on Health, where all the state commissioners of health are members, and we discuss with so we want to tell them, what to do, how to collaborate and how to, have this understanding for the good of us all. But I'm saying that we cannot. It's just like the Child Rights Act. The Child Rights Act has been domesticated in some states. But again, domestication does not necessarily translate into implementation. So it can be domesticated, but the implementation will still have to. But in this particular one, it's again a function of the ability of the states to. We appreciate that where they do, because that's part of the advocacy, that's part of the engagement we have with them. But I'm saying that to now hold the federal government responsible, that is what I say is not fair. That's the point I'm making. Now, and the same thing goes for FCT.
Now, you also spoke about
the FCT.
Just one moment, Honorable Minister. You spoke about the collaboration with the states now, and that there is a National Council of Health that interfaces federal and state health delivery systems. For the states, and from the conversations you may be aware of, is it a problem of funding that the states have, which is making it impossible or difficult for them to remunerate their health workers adequately? Or what exactly do you think may be the reason, or you have found out is the reason that, you know, the sin of the son, as you said, is being visited on the father?
Yes, you are right. You know, my understanding, or my own understanding is that of, you know, non-availability of inadequacy of funds available to implement. That is the issue that I have seen with the states. It's not because they don't want to, generally, but inability, because they also have their own, they have to determine their own priorities. But we say that, look, health should come first. That is our own position, and we try to also make, we do know that at least most of them, they really mean well, and they know that they have to do more in terms of guarding the health of the people of their respective states.
Right. Just to put this in context, 16,000 doctors have down tools, basically saying that we're short-staffed in a sector that we were even short-staffed before now. 16,000 doctors are out. And, you know, they put out their demands, and they said that this is just resuming the strike they embarked on, or they suspended in June. They said they gave government 10 weeks to meet their demands. And one of the issues they raised, which is quite germane, is regarding insurance. They say that the doctors that lost their lives in the line of duty, that their families have not been compensated, they've not been paid that insurance till this point. And that's one of the issues that they raised. They said they've given government 10 weeks to actually meet this. So, and we know that there was that meeting with the Speaker of the House of Representatives at the federal level, and this seemed like it was sorted. But here we are right now. So regarding that insurance, what is the issue?
Okay. Yes. Now, every federal government or every worker in the federal civil service is entitled to this group life insurance thing, which is domiciled in the office of the head of civil service of the Federation. That is a group life thing. And we discussed this at our previous engagements with doctors. And we did say that you need to come up with this information to the and all the relevant officials, particularly in the office of the head of the civil service. Relevant officials were present so that they will know who to direct these things to. What we just do in the Ministry of Health is supervision of the process. So when somebody dies, a doctor, a health worker dies, and is an employee of the federal government, the information comes to us, it goes to our HR, Human Resources Directorate, is processed. And of course, ours is to just do a follow-up. But in terms of getting this done, it's through the office of the head of civil service. That's the thing. We just supervise and ensure, because they are the one that will interface with the insurance company, because it's a group of insurance companies that manage this process. But what we have discovered is that most of the time, or some of the time, the appropriate information is not made available. For example, we have asked the various federal tertiary hospitals in the under the federal government to come up with a nominal role. So we know who is on that list and stands to benefit if, unfortunately, that kind of thing happens. I mean, in the event that that kind of thing, that is death, we know we can easily follow through. And like I said, our role in the Ministry of Health is that of supervision. It's handled, and the thing is domiciled at the office of the head of civil service of the Federation. And they then liaise with the relevant insurance. But all the, again, like I said earlier on, the documentation process and the bureaucracy and all that. These are some of the things. And we made that clear, and the doctors told us that they understand better now. At that point in time.
So
that's the thing.
Right.
It's not with us in the Federal Ministry of Health.
Well, you have talked about the head of civil service, and we do hope that those issues will be resolved. But another issue they have raised, which you have talked about, is the inducement fee. You said, yes, the hazard allowance has been suspended, but you have looked into inducement allowance now just to ensure that they are covered. But you mentioned that just part of June has been paid, so that's leaving the rest of June and August. And you said earlier on that you are trying to collate the list of the doctors. Is that something that is ongoing? What is the plan for paying those allowances? Because that is one of the issues they have raised.
Yes, you see, we discovered that from the list, because the various heads of these institutions, they generate those that are captured, because they are there. They know who works at the treatment center, who works at the isolation center. And of course, the isolation and treatment, it's pay as you go. Because it's not every time that you have people working at the treatment center. You may not have even anybody on admission at the treatment center at a given point in time. So there will not be need to pay. So it's based on what they generate and send to us. But having said that,
okay,
I also do know that we.
Yes, go ahead, please.
Yes, that we still have to source. You see, the initial computation we had from the ministry, from the records available to us, it was in excess of 70 billion. Initial computation. But we had to scale it down based on other realities. And when we took off in April, the Federal Ministry of Finance, Budget and Economic, and National Planning was able to source for 20 billion that they put down to cater for a 3-month period. But we discovered in the process of implementation, because they were then having a lot of figures based on what we were also given from the various centers, we discovered that what we had could only cater for a little above 2 months, but not even reaching the entire 3-month period. So that was how we got stuck. And at each point in time, we tried to explain this and say we are working. It's work in progress. Because it's not as if the money is is stuck somewhere. No.
Okay, part of their understanding
is we do not pay the money.
Part of what they understand is that, pardon me, they were saying that about some of this COVID allowance, that 6 out of 54 hospitals were paid and that the others have not received any payment. That's what they say.
You see, you don't forget, it's not even the hospitals alone. There are other establishments that have generated figures. They have generated lists of those of their staff that are in one way also involved. We have centers, medical laboratory, medical laboratory people who are not necessarily in hospital, but BB specimens are taken to them and all that. They are also exposed somehow. So we have so many other things that were not even, they were inadvertently not captured even at the beginning. But when these people now saw that payments are being made, they now had to come up. And all this, we needed to interrogate and be sure of what we are pushing forward for payment. So these are some of the issues. But again, the Federal Ministry of Finance is sourcing, is looking for funds here and there to really pay, because the commitment is there, right from the highest level of government. And Mr. President is so concerned about all this, and we are also working.
And speaking about the funds,
to see that we get this in so that, and we have continued.
You did say, pardon me, you mentioned earlier that 20 billion has been paid. Could you give us a breakdown of who and who were paid this 20 billion?
I have just mentioned from the list of those that qualify. The list is being generated all over across the federal medical centers, university, federal teaching hospitals, federal medical centers, other centers. You have neuropsychiatric centers. You have orthopedic hospitals. Those are federal institutions, federal tertiary, health institutions that are generating all these figures, lists for us that we need to look at and then push them on to the relevant authorities for evaluation and capturing. This is what happens.
So is that the list that was being collated? How far have you gone with that list? I mean, does NARD understand that, well, this is what is going on, and it's not just NARD, and then you have other affiliate unions, which we'll come to in a moment. Do they know that this is the process? Because if they do, one wonders then, why will they embark on strike if they have this clear communication from the ministry?
Well, you see, Chamberlain, I can assure you that at each point in time, we carry them along, we let them know what is happening. And don't forget, there are other issues that were raised before this time that we were able to resolve. Like the crisis in University of Port Harcourt Teaching Hospital, in the local chapter of the ARD, Association of Resident Doctors of the University of Port Harcourt Teaching Hospital, with the NARD, the national body. We resolved the thing. The issue of University of JOHESU Teaching Hospital, where the doctors that, by a fluctuation of time, that is, by time they have retired, that and then they were accusing us of dismissing them. No, we did not do that. Their time was up, but because we had promised that those who will be retiring, rather than sourcing for fresh people to help in this COVID-19 period, we had to reabsorb them into the system. So we resolved all that, because those are part of the issues brought up in the previous months, leading to all this. So these are some of the things. So a lot of things come up which we look at and we evaluate, and we look at how genuine these issues are, and we try to do our best. And we have at every point in time appealed, and we are still appealing to doctors to just bear with us, that we look at some of these demands that are very legitimate, and that we are doing our best to address them within the ambit of funds available.
We may need to be a little more. Just one moment, Honourable Minister.
It's not just doctors. That's why I have continued to talk about health workers.
Yeah, we may need to be a little more persuasive,
workers,
because
not just doctors.
I don't think that the message is percolating as one would expect. One reason for that is, while these issues with NARD are being addressed, JOHESU has placed us on standby. They also have put out a notice that they're going to go on strike September 14. If by midnight of September 13, their demands are not met. In fact, some of the demands, according to them, date back some 10 years. They've been engaging on some of these issues since 2014, and that it culminated on their strike of April 17, 2018, and some of those issues have not been met. This time, they said there's a 7-day warning strike for all federal health institutions, and states should be on standby. Can we avert this?
You see, thank you very much. I can assure you that at every point in time, I have carefully ensured that, in terms of choosing my words, I have not just talked about doctors. I have talked about health workers, because I don't need to be told that, the healthcare delivery is a team effort, and everyone that is in that team is important. So, but what we have discovered is that the moment you try to solve one particular issue, some of these bodies, they introduce another one. The moment you try to solve that, they introduce another one. So it becomes virtually, endless situation, which I want to say with all due sense of, modesty and respect, that may not be fair to the system. That will not be fair to the system. We are looking at this. I mentioned earlier, and some of these demands, they are legitimate. No doubt about that. But that we also need to show understanding within the ambit of the realities at the moment. There are so many issues competing for the limited resources available. What we now try to do is to prioritize as much as possible and ask for the understanding. That's why we continue to appeal to all the health workers, not just doctors, all the health workers. And that's why I want to really thank those doctors who, as we speak, in the introductory clip that we showed, Lagos is there. They are working. They are working. No evidence of any strike action going on. So it is this attitude of understanding. We are not saying that they forgo what they should earn legitimately, but we are saying that we also have a duty even to protect these workers.
JOHESU.
We have a duty.
JOHESU in particular.
From the Federal Ministry of Health.
For JOHESU.
But we cannot do whatever on our own. We still have to liaise with other ministries and agencies of government.
Right. For JOHESU in particular, they're saying that they think the government is paying lip service to conciliatory agreements, which is why they're planning to go on that strike. And for them, they're saying that if those demands are not met, basically saying that we agreed on these things and they've not been met. But, there's a lot really to talk about in the health sector, especially now that there is global health pandemic. And I'd like to quickly touch on this one just before we round off. A lot of travelers are saying that they're not entirely sure where to get tested, especially because of arbitrary test fees. They say some people are charging 42,000 naira to get tested. So is there a standard fee for getting tested, especially for travelers who have to present, their test results just, a few hours before travel? So is there a standard fee for testing? Is it free? Where should people go to?
Well, we cannot talk about any standard fee because it depends on where you are taking it. Because we allow some accredited private laboratories to do the testing. So if for one reason or other a particular private laboratory decides to charge 10,000 and another one decides to charge 12,000, for as long as they are private laboratories, we don't have control over that. What we are interested in is that lab, the private lab, has been accredited to carry out the test. So we cannot determine for them it's probably the government centers that they may, if at all they have to charge, they may charge a uniform amount if they so wish. But we don't really have control. What we are interested in is to produce a certificate of COVID-free. That's all we are interested in.
In fact, when they hear 72, that's even not midway, because I know some charge 75,000 naira if you want your results real quick. So that's just as an aside. But could you tell us, what is government thinking about the vaccines received from Russia? Are we going to distribute it, administer it, or what?
Well, Chamberlain, I think the Honourable Minister already issued a statement, and I also had to respond to from some of your media colleagues. We never, I repeat, we did not receive vaccines from Russia. What happened was that His Excellency, the ambassador, the Russian ambassador, came in company of the deputy head of mission. It's just to present aid memoir, which is a kind of diplomatic communication, to us, to the effect that they already have a vaccine developed in Russia, which is undergoing clinical trial. Has gone through phase 1, phase 2, and now in the phase 3. And hoping that if it's concluded in the phase 3, which is the last phase in terms of clinical trial, then it will be made available for use. And that vaccine has not even been released in Russia itself. So it's just for us to be notified and possibly indicate interest, just in case it is certified. And when I mean certified, because even when a vaccine is produced, it still has to be subjected to our own processes here in Nigeria, particularly through NAFDAC. That's one of the reasons why NAFDAC is there. So no vaccines were brought to us. No, it is. I think it's a wrong information out there, which we have tried to, from that very day since we got it on news, we have tried to correct it. So it is not true.
All
the
right,
vaccine, when it as at today, you have about 230 vaccine candidates, all over the world that, various countries are working on here and there. But it's a cumbersome process. And even when, like I said, the phase 3 is the final, which will now, it will involve several thousands of people, because there are so many things to be checked. And when it's even determining that, it will still have to come here before we can, because this is something that we're going to apply to a lot of people, masses. So you cannot afford to take chances. And that's why NAFDAC is there, to check for the safety, the efficacy, and across board. Because the vaccines, you want to know, is it just meant for children? Is it meant for adults? Even if it's adults, is it meant for a particular age group? Again, can you apply it in the presence of comorbidities, that is, other existing illnesses? These are so many things to be checked before you can then push it out and say, yes, you can apply. Because it's vaccines, which means so many people will be, it's going to be of mass application. So you cannot afford to take chances. We have not got to that stage at all, because even the vaccine itself is not yet released in Russia. So how can we have it here when it's not even released in Russia? Russia is still in phase 3 of the clinical trial.
All right, well, then that's due to at least let them hear that from you again, because some were already distorting and asking questions about that. So good that you shed a lot more light on that. Well, we do hope that the meeting goes well today with the resident doctors, and that even JOHESU as well will sheath their sword moving forward. And thank you for talking to us today, Minister.
Thank you very much for inviting me, and thank you for also helping us to put the situation in the right perspective and hearing from us as to what we are doing. We want to still appeal to all our health workers to please bear with us. We are doing the best we can in the circumstance to also protect their own interests, but we also want them to understand the situation in which we are in.
All right, then.